Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome to the channel of Easy Medical Notes, which is a summary of standard medical textbooks like Harrison, Davidson, McMaster, Oxford, and Pocket Medicine. We are on the way of discussing the cardinal symptoms of respiratory as well as cardiac system. So previously we have discussed about chest pain. Today we will discuss about hemoptysis. So let's start. So first, what is hemoptysis? What is hemoptysis? Hemoptysis is nothing but defined as expectoration of blood or blood streaked sputum. It is nothing but coughing of a blood or streaking of blood on the sputum. Now, hemoptysis can be massive or non-massive because the management is different for both. So we divide it into massive or non-massive. So massive hemoptysis means more than 100 ml of blood is expectorated in 1 hour or more than 500 ml, and in some books it says, like in Harrison it is 400 ml in 24 hours. So 100 ml in 1 hour or 4 to 500 ml in 24 hours is considered as a massive hemoptysis, but practically it is not possible to estimate or measure the amount of that blood. So Harrison says uh, to ask the patient in terms of uh, uh, like this. If one glass measures approximately around 200 ml, one drinking glass of water measures around 200 ml of 200 ml. So if more than half of a glass of drinking water per hour blood is expectorated, then it is called as massive hemoptysis. Or more than 2 to 3 glasses of blood is expectorated in 24 hours, then it is called as massive hemoptysis. More than half per hour or more than 2 to 3 glasses per hour. So what is the etiopathogenesis? Bleeding can originate from two sources: bronchial arteries and pulmonary arteries. Nearly the entire cardiac output traverses through the low pressure pulmonary arteries, while the bronchial arteries are under much high pressure. Bronchial arteries are high pressure but carry only a small fraction of the total cardiac output. Bleeding from high pressure bronchial vessels is the cause, particularly in the setting of massive hepatitis. So, main cause is bleeding from bronchial vessels, particularly in massive hepatitis, as the bronchial arteries are the vascular supply of the large airways. Hemoptysis, this is important point, hemoptysis must always be assumed to have a serious cause until this is excluded. This is according to Davidson. Okay. Now, what are the causes of hemoptysis? So you can remember in two manner the causes of hemoptysis. One is, it can be bronchial cause, it can be parenchymal cause, lung vascular cause, cardiovascular cause, or blood disorders. Bronchial cause, common causes are carcinoma, bronchiectasis, acute bronchitis, acute bronchitis. Parenchymal causes, tuberculosis, most common cause. Other causes like suppurative pneumonia, lung abscess, fungal ball, these are other causes. Lung vascular disease, most common causes pulmonary infarction and other vasculitis. Most common causes pulmonary infarction, that is pulmonary embolism. Cardiovascular cause, most common cause acute left ventricular failure, pink frothy sputum, and also mitral stenosis. Blood disorders like leukemia, hemophilia, patients on anticoagulants, these are all causes for hemoptysis. Bronchial cause, remember, bronchial disease, common causes cancer, bronchiectasis and acute bronchitis. Parenchymal cause tuberculosis, vascular cause infarction, and cardiovascular cause acute LVF. Now next, moving on to the next page. So other type of classification is like this, and this is, I think, easy to remember and more practical. The first cause can be infection and inflammation. In that, Bronchitis, acute bronchitis is the most common cause of trivial, trivial meaning small amount of hemoptysis. Patient come with, oh, sir, I am having, I had some blood in my sputum. Frequently with upper respiratory tract infections, which also have LRTI, they come with this complaint. So the most common cause of acute bronchitis is trivial hemoptysis is bronchitis. Yes, so it can be infection. Second is bronchiectasis and cystic fibrosis. These two are the common causes of hemoptysis. Bronchiectasis, a chronic smoker with repeated exacerbations, or a patient of past treated tuberculosis can have bronchiectasis. They can come with massive hemoptysis. So these two are common causes which are highlighted here. Tuberculosis in India is also a common cause of massive hemoptysis, and it is irrespective of whether the TB is active or inactive, or and whether the patient is treated or not treated, irrespective. So these are the and causes of pneumonia can be there, lung abscess can be there. So common causes are remember, bronchitis, bronchiectasis and tuberculosis. Next, neoplasm, so lung cancer. Cardiovascular cause, pulmonary embolism, common cause. And acute left ventricular failure, pink frothy sputum. Okay, other causes include vasculitis. So this is very easy to remember: infection, malignancy, cardiovascular cause, other causes. Okay, then moving on forwards. So the most frequent causes of massive hemoptysis are malignancy, bronchiectasis, tuberculosis. Remember this. These are most important and frequent causes: malignancy, bronchiectasis, and tuberculosis. Trauma and any bleeding disorder, or a patient with patient on anticoagulants. These are the five most frequent causes of massive hepatitis. Now, frequent causes of non-massive hemoptysis, that was massive. Those are also similar, just include acute bronchitis in this one. So acute bronchitis is the most common cause of non-massive hemoptysis, followed by bronchiectasis, tuberculosis, lung carcinoma, pneumonia. These are the causes. Okay, that is non-massive hemoptysis. Hemoptysis is a common complication of pulmonary tuberculosis, and it is seen in 30 to 35% of patients. Hemoptysis may present as the initial manifestation of active tuberculosis or can develop during the course of treatment also. It may also occur as a sequela even after the disease is non-active and microbiologically cured. Also keep in mind that even in the presence of active or previous tuberculosis, hemoptysis may be caused by different diseases. Okay, so remember the most frequent causes of massive hepatitis and the frequent causes of non-massive hepatitis. So in that you remember acute infections like bronchitis and bacterial pneumonia. Bacterial pneumonia. Now moving on forwards. Moving on forwards. So what are the clinical features? So there will be blood along with sputum. So first what you do, you exclude any ENT bleed, ear, nose, throat bleed due to some upper respiratory infection, sinusitis, rhinitis, okay, pharyngitis. So exclude that. Then bleeding from gums and hemoptysis, vomiting of blood. These three you should exclude. So bleeding from ENT causes, bleeding from gums, and vomiting. So you will have food particles when you vomit blood. Okay, that's how you differentiate. Next, if the uh, patient has fever and chills, then the causes can be acute bronchitis, pneumonia, lung abscess. If the patient is smoking and has recurrent hemoptysis, then the cause can be lung cancer, If the patient has sudden onset hemoptysis with severe chest pain and dyspnea, then the cause can be pulmonary embolism. Patient has history of chest trauma or invasive diagnostic procedures, then trauma-induced hemoptysis. If patient has vasculitis or any connective tissue disease, there will be hemoptysis along with manifestation of the CTD, like there can be rash, hematuria, digital infarcts, digital infarcts. Okay, if the cause is due to vasculitis. Next is if the patient has considerable weight loss. Considerable weight loss is nothing but a loss of more than 10% of weight within 6 months. Okay, so the cause can be cancer, tuberculosis, and systemic inflammatory condition like connective tissue disorders. If the patient has paroxysmal nocturnal dyspnea, PND, and exertional dyspnea, so it is a feature of chronic heart failure. So the cause can be left ventricular failure and mitral stenosis. So that is one. From history you have some clues. Then sputum characteristics. Massive expectoration of blood stained sputum is suggestive of blood stained sputum is a bronchiectasis. Purulent and bloody sputum, purulent sputum, that means acute bronchitis, bronchiectasis, if accompanied by fever, pneumonia, or pulmonary abscesses. Pink frothy sputum, left ventricular failure, mitral stenosis. Expectoration of pure blood, remember lung cancer, tuberculosis, pulmonary embolism. So these are important causes of expectoration of pure blood, lung carcinoma, and tuberculosis due to invasion of the granulomas into the bronchial arteries, and pulmonary embolism. Pulmonary embolism. These are frank blood they will expectorate. So now moving on to the investigations next. So what are the investigations you do? You will do X-ray, chest X-ray. There will be evidence of a localized lesion like tumor or pneumonia or some fungal ball or tuberculosis. You order CBC and blood coagulation tests like PTINR and EPT. If there is sputum, you do sputum culture and stain for bacteria, fungi, and also acid fast bacilli for TB, and cytology to rule out malignancy. So these are the basic first line tests for hemoptysis. Remember, chest X-ray, CBC, blood coagulation test, sputum culture and stain. These are first line test. First line test. If you don't reach the diagnosis by this, then you can move on to the second line tests, which are those are HRCT thorax. If the patient has risk factor for lung malignancy, presence of radiographic abnormalities on chest radiography, or concerning clinical course, bronchoscopy should be done after the acute bleed is settled, and it is both diagnostic also and it can be used as therapeutic purpose also. Okay, we will learn how it can use. Then next is CT angiography if pulmonary embolism is suspected. Next is other tests depending upon the clinical suspicion. Example, testing for tuberculosis, uh, anti-nuclear antibody, extractable nuclear antigens, anti-neutrophilic neutrophil cytoplasmic antibody, vasculitis, anti-glomerular basement membrane in a good pasture syndrome. This is in vasculitis. This is some connective tissue disorder, urinalysis to rule out vasculitis and pulmonary renal syndrome. So these are the tests. These are first line. These are the next line. Okay, HRCT thorax, bronchoscopy, HRCT thorax, bronchoscopy, and CT arteriography. Then other tests depending upon the suspicion. Okay, next, moving forwards. So this is the summary of our discussion. See, patient with hemoptysis, rule out ENT and hematemesis. Okay, based on history and physical examination, quantify the amount of bleed, whether it is massive or non-massive. If it is massive, then the first priority should be to protect the airway. Should be to protect the airway. Now, how you will protect the airway? You will intubate the normal lung, not the problematic lung. you intubate the normal lung to protect from asphyxiation. So blood, okay, so protect the airway. If bleeding stops, then okay. If bleeding continues, then do pulmonary embolization or resection of the lung. Okay, that's about the massive bleed. Second one, if the bleed is non-massive, then check risk factors. What are the risk factors? If the patient is more than 40 years, or if the patient is a chronic smoker. These are the two risk factor. Chronic smoker. If these are two risk factors are present, then you do the first line test. First line test. Okay. After doing the first line, if you have if you are not sure about the reason, then you can go to HRCT. Further, if you do you have doubt, yeah, you can do bronchoscopy, both for diagnostic purpose as well as therapeutic purpose. Then treat the underlying disease accordingly. If the bleeding is not settled by bronchoscopy also, persistent bleeding is there, then you will go for either embolization or resection of the affected lung. Okay. Now, if there are no risk factors, the patient is less than 40 years, there is no history of smoking and all, treat the underlying disease, which will usually be a infection. And if after treating also the patient with no risk factors, if he has persistent bleed, then you should do the first line test, then go on to the second line test, then this will be the chart. Okay, that's all about the summary of about hemoptysis. Moving forwards, see here what the patient when he coughs blood, no, he is so fiery that he thinks that I will die of due to bleeding only. But books say death is from asphyxiation, not from exsanguination. That means that is not death is not from bleeding, it is due to asphyxiation of the normal lung. The normal lung is also filled with blood, so because of that patient will not able to breathe and he will go into respiratory and cardiac arrest. So remember this point, in hemoptysis death is due to asphyxiation, not exsanguination. So that's why our goal is to maintain the gas exchange and reverse the coagulopathy and treat the underlying condition. Don't use cough suppressants because they will increase the risk of asphyxiation. Yes, of course, if the cough is suppressed, then the normal lung is easily filled with blood. So cough suppressants, if they are used, then that will cause asphyxiation easily. So our goal is to maintain to preserve the normal lung, to have the airway properly and treat the underlying condition. Now we have learnt about the management of non-massive hemoptysis. It is not so complicated. We will learn step by step the management of massive hemoptysis. So in massive hemoptysis, first maintain the airway and secure IV access. Transfer the patient to a monitored unit with frequent vital signs assessment. Second, put bleeding site dependent. So the affected lung site, you put the patient. Selectively intubate the normal lung. If needed, consider placing the tube in the main bronchus of the opposite lung. Placement of a double lumen tube is an alternative solution. Then start oxygen therapy. Maintain oxygen saturation more than 90%. Don't go more than 94 to 96%, as we have learned in previous classes. Then, so first aid measures you have given, you have secured the airway, you have secured the IV line, you have given the oxygen therapy. Then you do a chest radiography, first line test. Okay. Then next, correct any coagulation abnormalities, and from bleeding, if there is anemia, correct that. Hypovolemia, correct. First line test, then correct all these things. Then infusions or inhalations of the antifibrinolytic agent like tranexamic acid you can try, or the vasopressin precursor like terlipressin may help to limit bleeding, but the evidence of efficacy is limited. You can try these drugs, antifibrinolytic drugs like tranexamic acid injection pause. It is available, injection pause in the form of injection pause in medical stores. Okay. Now, if the massive hemoptysis, if the bleeding is settled by these measures only, don't go forwards. If it is not settled, then after if there is persistent bleed, then you go for bronchoscopy. It can serve both diagnostic and therapeutic purposes. You can do by bronchoscopy, balloon tamponade. By balloon, you can block, you can compress the bleeding artery, or iced saline lavage. So that will cause vasoconstriction of the vessels. Application of a topical vasoconstrictive agents, cryotherapy, guiding double lumen endotracheal tube positioning. So by bronchoscopy, you can try to stop the bleed, massive bleed through bronchoscopy like this. Now, after bronchoscopy, if bleeding persists, then do CT arteriography of the lung, and which will serve as diagnosis also, and then therapeutic embolization of that artery which is bleeding. But this has the risk of spinal artery embolization also. Spinal artery embolization. So that is the risk of therapeutic embolization of the bleeding artery. If after that also the bleeding is not subsiding, then what you will do? Unilateral uncontrolled bleeding should warrant thoracic surgery, consultation for consideration of resection of the affected lobe of the lung if the convention measures outlined above are not successful. So first you will protect the lung and oxygenate the lung. First you will protect the lung and oxygenate the lung, not not and correct all those abnormalities which are there. You will do first line investigations. You will give first aid measures. If the bleeding is not subsiding, you will go for bronchoscopy. Not subsiding, you will go for CT arteriography with embolization. Still not stopping, then you will go for resection of the lung. So with this, we complete our topic of hemoptysis. Next, we will discuss the next topic afterwards. Thank you for watching.